Thank you. First, I would like to thank our chorus team for arranging this webinar and giving me the opportunity to talk about the public expenditure tracking and national health account, which are really excellent tools for expenditure tracking. Following the last webinar, I think today I will very briefly talk about the practical examples that can be used at the country level. So I will give examples of national health accounts and as Professor Tim mentioned, I will give experience or examples from Bangladesh and also public expenditure tracking survey examples from Bangladesh. And then we'll break out in rooms and we'll discuss questions and then come back and share our reflection from the breakout room. So national health accounts, what is national health accounts? So national health accounts, it is a process that identifies the total health expenditure of what? Maybe it can be total health expenditure of a country across all the ministries, or maybe it is the total health expenditure focusing on only Ministry of Health or Ministry of Health and Population, whatever is called in any country. So the total amount of health expenditure of the country. And national health accounts also traces the sources of health expenditure. So how the funding is coming, how the money is coming, who is providing? Is it the government providing the money for spending, or is it the development partners, NGO providers, or any private sector, or maybe people of their own pockets? So what are the sources of these health expenditure? And national health accounts also helps to identify the distribution of funds by functions. That is the funding or is the expenditure used for preventive care or curative care? Is it for primary health care, tertiary level, or secondary care? So how the fund is actually being spent by different functions. And national health accounts also helps to trace the channel of distribution of funds by inputs or line items. For example, is the fund being spent for salaries or medicine or maintenance or buying vehicles? So what a country spends on health, how the sources of funding is coming from different types of source, how the fund is being spent by type of service or even by line items. All these can be tracked or analyzed using national health accounts. So it's really an important tool for a country to understand how the country is spending money on health. And that really helps the policymakers to make policy more accurately and better way. There are international standards for doing national health accounts. So there are international classification on health expenditures. I very loosely explained different sources, how the fund can spend by line items, but there are international tools and definition to define all of these. What do we mean by function? What do we mean by provider? What do we mean by financing schemes or financing agents? So there are different standard definition. These are used by the country to estimate national health accounts. This is because then we can compare across different countries. If every country use their own definition of the function or provider or scheme or agent, then we cannot compare the national health account or the expenditure on health of one country with another. So it is good that countries uses the standard methods of estimating national health accounts. Having said that, of course, there are differences across countries and they have to adapt. So it is good to flag those changes. So how we define, basically, I will show a flow diagram very briefly that how fund flows. So financing, there are revenues of scheme to the right hand side here, the box. You can see that there can be government schemes, there can be voluntary health insurance, non-profit institute or NGO financing scheme can be there, corporation, autonomous bodies, private companies. Other than the health insurance, they can also provide funding for health expenditure. People often use the money of their own pocket. They spend from their salary, or even they sell their land and resources to pay for health expenditure. So this is known as out-of-pocket health expenditure that people spend when they really seek the care at the point of service delivery. So people also spend from their own pocket, and rest of the world development partners often, pay for government, pay towards government to pay for health expenditure. So all these revenue schemes, those are the different financing schemes. Those resources can then flow to the service providers. So somehow either government can provide the funding, development partners, or through insurance risk pooling mechanism, international NGOs, any corporate sector, corporate social responsibilities, any individual. So all these financing sources then go to the providers. Ultimately, we pay to the providers for providing the care. And then from the providers, the fund then flows, or the benefits, health services and functions goes to the beneficiaries. So National Health Accounts tries to track all these, that which are the revenues of schemes, how these funds are coming, and then how they are channeling towards different providers and beneficiaries. So National Health Accounts mainly tends to answer a few questions. So first question is, how much is spent for health in the country? So is it X amount, million, billion, how much? Entirely the country spends for health. And maybe I'm traveling to some other country for seeking my health care, but still I'm spending for health. So that comes into the country's overall spending. If I seek care from the country, it is also included in my health expenditure. So collectively, a country, how much they spend. And as I was saying, the government also spends. There is infrastructure and other. Government also spends through their tax-based funding. There can be insurance, but ultimately how much in total, and who pays? As I was saying, that is it government paying, people by their selves, out-of-pocket expenditure, development partners, and who is paying how much? How much government is paying? How much development partners are contributing? How much in the contribution of the insurance, maybe through the employees? So how much, who is paying? And then how the expenditure is distributed across different services. I just said this before. So this can be answered, this question, that how the expenditures are distributed across different services and across different providers. Is the country spending more on primary healthcare, or the country is spending more on clinical care and for the tertiary healthcare? Who are the providers who are getting the resources and providing services? Is it the community clinics, frontline health workers, or tertiary hospitals? What services are being provided? So these can be traced through National Health Accounts, and who is benefited and how much. So National Health Accounts also traces that how much spending is done by different income groups, by different regions, by different disease profiles. So maybe more sort of preventive, promotive care, or cancer or other treatments. So these can be done with more sophisticated process of National Health Accounts. I will give a few examples from the National Health Accounts that has been conducted in Bangladesh, which will give the examples of what information we can get from National Health Accounts. As I was saying, what questions National Health Accounts tries to address. So if we look into this diagram, it shows that how much resources are spent by out-of-pocket health expenditure, or government, or rest of the world, or voluntary payment scheme. So in Bangladesh, if we spend 100 taka on health, out of this 100 taka, households, they spend by themselves out-of-pocket expenditure 67 taka, or US dollar, whatever unit we use. So 67% of total health expenditure is actually borne by the people, by the persons themselves. This is the out-of-pocket expenditure. It is really very high. And government spends 23% of the total health expenditure. And this is from the Bangladesh National Health Account 2017. Data was used till 2015. So government's share in the total health expenditure is quite low than expected. It is only 23% in Bangladesh. And rest of the world means the development partners, international NGOs all together, and even some from NGOs. But NGOs, generally, they also get funding from development partners or other voluntary, companies, or some donation. So this is only 7%. And any other voluntary payment schemes, any prepayment mechanism, insurance is really low in the country. And even these 3% includes health insurance, some other NGOs, corporations, autonomous bodies, all these together comprises 3%. So if we look into the geographic distribution of total health expenditure, so this diagram shows by division, so in different parts of the country, and national health accounts really helps to see that how much spending on health are having in different parts of the country. And you can see that Dhaka, the capital of Bangladesh, is spending 46% of total health expenditure. So out of the total health expenditure in the country, the largest share is spent in Dhaka, the capital city, 46%. And then we can see that the lowest amount is in Sylhet and Borishal. These two divisions, they are getting only 4% of total expenditure is done in Sylhet and Borishal. And you can see Rangpur, Khulna, Rajshahi, these are also like from 7% to 16% varies. So this shows that definitely the total health expenditure varies across different divisions. But anyway, divisions can be different in terms of number of population. So we need to understand that what is the per capita expenditure also across these divisions, because some division may have more population. So spending can be more in those areas. But if we then look into the right hand side, the per capita total health expenditure per capita by division, then you can also see that per head expenditure also varies across these divisions. And here again, the highest per capita total health expenditure is in Dhaka, which is around 4,000 Bangladeshi taka, whereas followed by like Khulna, it is 3,300. So this diagram shows that the per capita expenditure, total health expenditure, also varies across the country, and that shows some inherent inequity, even if only we assume that at least the population has same demographic or other healthcare need. At least per capita spending varies across these divisions. Then if we look into that, as I was saying, where do we spend these total health expenditure? So we can see that around 47% of the total health expenditure is spent on medicine or like medical goods, 47%. And then around 11% is spent on preventive care, and 25% is services of curative care, long-term and rehabilitative care, only 0.1%. So these national health accounts really shows us that the expenditure is really low on long-term and rehabilitative care. In Bangladesh, if we see the population pyramid, we have major portion of the people are now young, and they are like at their productive age. But the population pyramid will not remain the same. In next 15 to 20 years, we may see that the population pyramid might change. This diagram at least reflects that the spending on long-term care or rehabilitative care is really low in the country. And gross capital in formulation is 6%, and you see that our system is more focusing on clinical care and less focus on sometimes we say that preventive care. So this diagram also shows that 11% of the total health expenditure is going for preventive care. And we always say that research and training of health personnel, this is so important, but only 2% of the total health expenditure is gone for research, education, and training. So definitely this reflects the fact that medical goods are the item we are spending heavily on, as opposed to the education, research, we are spending quite less compared to many other countries. Now, as we are saying that how we are spending. So we are analyzing the total health expenditure from different lens. And this diagram shows that how we are spending on hospitals and provide healthcare system, administrative function, and other, retailers and other providers of medical goods, and then also some ancillary services. So these also shows, I don't know if you can see those diagram properly. So you can see the absolute amount and also the percentage. But here also retailers and other providers of medical goods really consume the big chunk of the expenditure, 43%, but public health programs only 3.7%. So as the previous diagram, you also could see that preventive care is really getting less expenditure in the country. So our focus is mainly on clinical care, and this diagram also shows that public health programs are really low amount compared to other expenditure groups. And also providers of healthcare system, administration and financing, this is 3.8%, and hospitals is 25.4%. So spending on the hospital is relatively high compared to the public health programs in the country. This diagram shows a comparison of public health expenditure as percentage of total health expenditure across different countries. This is the this is the South Asian Association of Regional Cooperation, South Asian regional cooperation of multiple nations. So if we compare their out-of-pocket public expenditure as percentage of total health expenditure, there are two tables. I will show the out-of-pocket expenditure next, but this slide shows the public expenditure as percentage of total health expenditure. So we expect that in a country like Bangladesh, government should provide more investment for health, and health expenditure, the total health expenditure should have a larger chunk from the public sector. But the public expenditure as percentage of total health expenditure in 2014 now was 28%. Whereas Afghanistan, Bhutan, India, if we look into other countries, if we compare these, we see that even in Bhutan, public expenditure as percentage of total health expenditure is 73%. In India, that is 30%, not very high than Bangladesh, and Nepal, it is 40%. But just to mention that this was taken from other sources, and when we did this is the WHO source, but when we did the national health accounts in 2015, we found that these contribution of the government went even down, and it came to 23%. And currently the latest round of national health accounts is in the process in the country. They have not disclosed the results, but informally we found that this has not gone much up. Rather, it's almost like stagnant, and still the 23% of the total health expenditure is borne by the public sector, that is the government. I don't know if I just changed, sorry for this. I don't know if shall I stop and answer a few questions and then go to public expenditure tracking? Would that be helpful, or shall I just continue and
yeah, maybe Rumana, maybe we could just break briefly for a couple, any clarifying questions. Would anyone have any questions to clarify what Rumana has said so far? No.
I can see Helen has one question.
Yes.
What is the population? Yeah, so it is actually, Helen, you are absolutely right, because the expenditure in a division, definitely the cross-boundary flow is quite high in Bangladesh, and especially people just come to Dhaka or bigger hospitals. So this is obviously an issue, but national health accounts, they consider data from multiple sources, and they come up with a weighted like population. So they take the population census data, they extrapolate from there. And also in the divisional level, there are information about the number of population. Of course, division also collects these from the district or sub-district level. So from these, they consider, try to do the estimation of the considering the boundaries, basically following the census, where people really registered during the census. But it is not that who is taking services from which facility, rather it's the district boundary. But again, this is a very good question. I will go back to the team now who are doing the national health accounts this round, and maybe I will ask them to clarify this even more prominently in the next report, so that this is answered even more accurately.
Thanks. Any other quick questions? Don't see anyone.
Okay.
I had one. I put in the chat.
Oh,
yeah. Data accuracy, there are multiple issues. I will very briefly say a few of these. For example, when we collect the data for national health accounts, the first issue is some organization, maybe in development partners or even the private sector, they keep the data in January to December calendar. And some keep the data from April to March. So different organizations have different calendar year. So when we estimate the national health accounts for a specific year, it always becomes a challenge to apportion that. Data reliability or validity that Joe is mentioning, definitely there are lots of assumptions that needs to be taken, because some data, there are some incomplete data always happens. And when the expenditure data are reconciled from Ministry of Health to Ministry of Finance or other ministries who also spend on health, so it is always not real-time data. So you have to wait when they all reconcile and you get the data that really ensures the quality and accuracy of these. So definitely there are challenges to get the reliable data, and national health accounts is heavily data driven, and it takes data from multiple ministries who spend on health, multiple sources. So tracking that, of course, is a huge task, but there is a trained team who are trying to overcome all these challenges. But definitely this is an issue, and they have to extrapolate, and they have to cross check with multiple sources and then use their justification to come up with a solution of using some data over other.
great. Thanks, Rumana. Shall we continue?
Sure.
Moving on to pets now.
Sure. So I will just go to pets now briefly. So yeah. So another tool, I'm sure that some of you or many of you joined the last webinar where Team and Brownie very nicely presented the public expenditure tracking, the concept. So from there, I thought it would be interesting to give a bit more practical experiences from Bangladesh, that how these are done in reality. So public expenditure, how we can track these, and why actually we track these, and what public expenditure tracking helps us in or how it helps us in policy making. So public expenditure, when we track that, this really helps to understand that what actually happens to the money that is allocated for service delivery. So once you allocate the money, are these being spent as you planned? What you have allocated, have this really arrived to the hospital? If it has arrived to the hospital, has they really spent? So it doesn't always mean that what you have allocated as budget, it will ultimately end up as spending at the facility level, at the hospital level. So these public expenditure tracking really helps to understand, as I was saying, that what happens in reality, how much is spent, how much remains underspent, if there is in any way any overspend, and if so, how you manage that. So what it is a reality check in that sense. And it also helps to detect the areas where the bottlenecks, where the challenges are in each stage of the budget cycle. That means, as I was trying to say, that you prepare a budget, that is your some sort of plan and estimation. Following the budget, then you allocate it, okay, I will disburse this amount following the budget. When you disburse, then it comes to the hospital. And after coming to the hospital of the disbursed amount against that budget, the hospital authority, they execute that, they spend that. So from starting from the planning to actual execution, is there any, as I was saying, underspending, overspending, any spending that was not actually planned but really happened? And what happened? Is this for a good reason, or it is deviating from original plan? And what are the challenges? So public expenditure tracking helps us to identify those challenges in the funding flow mechanism, starting from budgeting to the expenditure or execution of that. And it also helps to identify the areas from improvement. So when you find the challenges, definitely you get the opportunity to rectify yourself and to plan better in the next phase. And it also sometimes helps to identify what are the wastages, what are the leakages, and so that you can also improve yourself to stop or reduce those duplication, wastages, leakages at the facility level, or maybe any other level. So identify where the wastages are happening, why those are happening, really helps the policymakers to reduce that, to improve themselves, to ensure governance of financing in the system. So PETs can really help the policymakers and civil society for the budget analysis, for even doing the planning for future. So all these are, you can see the right hand, there's different tools, the PETs, national health accounts, public expenditure review, all these helps the budget analysis, but from different lens. So public expenditure tracking, as opposed to the national health accounts, looks into the more sort of ways of fund flow, whereas the national health accounts gives the macro picture, that how much funding is coming and where it is going in a broader terms. But public expenditure tracking is even more a deep dive and more focused of these budget analysis. And here there is opportunity to tally or compare what has been planned as budget and what has been spent. So that tracking really helps the policymaker to see that what is actually happening at the facility level and how to improve that. So PETs, as we're saying, can help the policymakers and civil society to understand the flows of fund and make informed policy decisions. More or less the same, the points that how it helps the policymakers in different ways, that why we do the public expenditure tracking. So it helps to prioritize and allocate of resources. It helps also, to do the human resource management or planning for the human resources. And also this helps the managers to implementation of the budget. It can help to promote equity, monitor different policies, and also help the audit of the facilities, because as I was saying, it identifies some bottlenecks. So that helps to improve that, and also that supports to avoid any audit objection for any mismatch that may take place while you deal with different financing schemes or modalities. So public expenditure tracking or public expenditure tracking surveys, this track the flow of public financial resources from the highest level of the government to the frontline service providers and beneficiaries, as we're trying to say. And this helps to identify the differences between the approved and actual allocation, determine how much of these approved allocations reach the service providers and ultimately the users. And this public expenditure tracking survey can help the policymakers, as we're saying, fund flows and all this. So I'm just duplicating myself. So we conducted a public expenditure tracking in Bangladesh in 2020-21. Report was published in 2022. So these, which was supported by the World Bank, and these public expenditure tracking survey, the objectives was to assess the process and the overall mechanism of budget formulation and the resource allocation for health facilities in Bangladesh, focusing mainly on the district level and below. Because you know that there are tertiary hospitals, there are specialized hospitals, but this public expenditure tracking did not look into those tertiary hospitals or specialized hospital. But in other countries or anywhere, this can also be included. But in Bangladesh, the recent one, it focused mainly district level and below for this tracking. And this public expenditure tracking, this determined how much of the approved resources, both cash and in kind. I'm giving this example because when we say the resource flows is not always only the financing. It can be human resources. It can be also drugs and logistics, medicine, surgical equipments, the definition can be broader. So we have to define the scope. So in Bangladesh, we also looked into both cash and in-kind resources that were sent from the center, what is received at this facility level, and how the facilities spent those. And we try to identify any delays or any discrepancies in this fund flow channel, that what's sent from the center, whether it arrived on time at the local level, if there is any delays or any discrepancy, if central level is saying that I have sent you X amount of X-ray machine, whether that arrived at the local level X amount, and if there is any discrepancy and if there is any differences, what are the reasons for that? So we examine the flows of fund and resources to health facilities, district and below level, to ensure that the equitable and efficient health service delivery can be ensured. And we also looked into the quantity and quality of service delivery, and also tried to provide operational level recommendation to the government. So I just gave the examples of the objectives, because these can be varied in countries depending on their need. We try to look into the equity issue, but there are other ways of looking into equity. So we should not consider that public expenditure tracking surveys should only focus on these. This can be adjusted depending on the country need. They can only focus on efficiency or equity or both, and can use other tools also as a complement to the public expenditure tracking survey. So how we actually carried out these tracking survey. So there were quantitative and qualitative components. In the quantitative part, we collected primary data from facilities, and the secondary data was collected from IBUS++. This is an integrated budget and accounting system managed by the Ministry of Finance. So all the ministries send their budget and expenditure data to IBUS, that is integrated budget and accounting system managed by the Ministry of Finance. So Ministry of Health has their financing data, and which they send to Ministry of Finance periodically, and some on real time, and Ministry of Finance also then tallies and keeps the record. So we collected data from the central level, because collecting the data from all the individual facilities may sometimes may not be feasible. So it might be easier to collect all these finance data from the Ministry of Finance. So we collected those from the Ministry of Finance. But as I was saying, from Ministry of Finance, we collected data, financial data for all the for all the districts, all 64 districts for the nation. But primary data from the center was collected from a subsample, because it was not possible to collect data from all these health facilities. So we took a subsample. And we also did some exit client interviews, and qualitative data, qualitative methods include desk review of literature, and also some key informant interviews to cross-check and validate what we have received from the two primary sources of the local level or secondary sources from IBUS. So we got some validation and also some information from the key informants. So very briefly, I will share some findings from these public expenditure tracking survey. So this survey showed that around 25% budget remains unspent across all the line items. So if we see There are two types of budget in Bangladesh. We do operating budget and development budget. Operating budget is mainly for the day-to-day expenditure, that is all the salaries, some medicine, all these, and maintenance, cleaning, cost for the fuel, all these, and some training goes to operating budget. And development budget is mainly for construction and also some heavy equipment. Though in Bangladesh, the development budget also provides some spending or some funding for staff cost. These are mainly project based staff costs, not like for the operating budget. These are not permanent positions. So there are some overlaps, but basically operating budget is for recurrent cost to cover those, and development budget for development spending for infrastructure development and other. These public expenditure tracking, where we looked into only the Ministry of Health and Family Welfare budget execution, and for 1 year only, 2019 and 20. So in 1 year, we found that 78% of the operating budget could be spent, where 22% around could not be spent for operating budget. And development budget, the portion was slightly lower, around 67% of the development budget could be spent, whereas around 31% they could not spend the money. So when we always talk about there are less funding for Ministry of Health or health altogether, but in reality is that whatever funding we are giving to Ministry of Health, they were not being able to spend the entire resources. This came up from the public expenditure tracking, that how much they could spend against the allocation. So budget was there, but they could not spend. So overall 75% could be spent, and around 25% of the allocated budget remained unspent. So this raises the question of efficiency of budget utilization, that given a resource scarce country or anywhere in the world, budget or funding is always scarce. You cannot do everything. And when you allocate some scarce resource to health ministry and they cannot spend those entirely, that definitely raises the question of efficiency of budget utilization. So that is an important dimension that these public expenditure tracking showed using the data from the local level, and also some from the central level data as well. So as I was saying, that public expenditure tracking, it also looks into that how much funding goes to different level also. So we tracked the expenditure by line item. So we looked into the district hospital, maternal and child welfare centers, and Upazila health complex. So district hospital, each district in Bangladesh has one district hospital and around one maternal and child welfare center. And the tier below the district is sub-district. So this is a sub-district health complex. We call that Upazila health complex. So public facilities at district level and below, they also could not fully utilize their operating budget. And if we see the spending across the line items, you can see these are the percentage of operating budget, where we see that even the pay of officers or pay of establishment, Upazila level, they could not spend all the money for the officers and the allowances. Every line item, you can see the underspending. But the issue that repair and maintenance also, you can see they could spend they could not spend bulk amount of funding. They could spend only 35% of their expenditure. So that really raises the question that the repair and maintenance, we always say that the equipments and others needs maintenance, and even the building and infrastructure needs maintenance. So despite having perceived need of repair and maintenance, at the district level, they could only spend 35% of their maintenance budget, and Upazila level also 58%, and rest remained unspent. The electricity bill, they spent 30%. So this raises the question whether when we prepared the budget, was that overestimation? That's why we could not spend the money, or is it something else that some lack of capacity of the local level who could not plan properly, or is it over ambitious budget? So this raises the challenges and questions at different levels, that why having a budget allocated for these line items we could not spend those. And of course the medical and surgical requisite, this includes the medicine and other supplies, logistics. Altogether it's called medical and surgical requisite in the country. And if you see that at the sub-district level, 66% budget could be spent. We always say that out-of-pocket expenditure is quite high. And the diagram earlier in the national health account showed that the bulk amount of the money is going for medical and surgical or buying medicine. And out-of-pocket expenditure is very high in Bangladesh. And the major reason is that we spend quite a high on medicine. But there are a budget for the medicine allocated for the Upazila level, sub-district or district level, but that could not be spent. If we would have been able to spend more of MSR budget, then the out-of-pocket expenditure might have been slightly lower. So we really have to find out that what are the reasons that we could not spend the money. So these questions are coming because we could do this public expenditure tracking and looked into the expenditure against the line item. So this gave us the opportunity to look into the inefficiencies or of resource utilization or underspending where we could not do. So underspending on MSR, why it occurred. So we did some in-depth interviews, as I mentioned earlier. So one of the reasons came that underspending on MSR occurs mainly due to the procurement delays in the procurement process, while underspending on salary, even under the operating budget, is mainly due to delay in recruitment against vacant posts. So when we found these findings, of course, we went to the policymakers and service providers to dig down that what are the reasons. And there are multiple reasons, but the main reasons were that when we plan for the procurement, it was done at the last moment, or even when we do the planning, but when it is approved at the central level and the medicine others are procured and sent to the local level, there remains a time lag. So that's why ultimately we could not spend the entire fund for the year, and it goes to the next year. So that's why, due to the delay in the procurement, for multiple reasons, for the approval, for the capacity at the local level for planning, and also the system requires some process to finally approve the procurement through a holistic process. This delay ultimately causes less spending of the funding. And underspending of salary, as even on the operating budget, these are regular. You know this, you have this number of staff. So why this is unspent? This is because that there are sometimes some vacant posts, and some people just retires, and some other happens that they just self-retire, or there are also some death or some other reasons, even migration. But filling those vacant posts takes really long, and then the post remains vacant and salary also comes, and that remains unspent for some time. Now, if we look into the percentage of Upazila Health Complex, that is the sub-district hospital, with availability of selected COVID-19 supplies as per need, we see that there are cases where the supply was quite good, but there are some areas where supply was really less. So these are the names, Bhola, Feni, of some sub-district hospital, some name of some areas, and each area we had a number of sub-district hospitals. Like Bhola had 6 sub-district hospitals, where Dinajpur had 12 sub-district hospital. So all this is showing the average number or percentage. So we can see that in Bhola, the personal protection equipments, PP, they received almost 100% there. But in Manikganj, they received only 67%. They said they have received those. Also the mask and oxygen and other, you see the variance. So the main, there are two, messages from this table. One is that the PETS helps to track not only the direct finance, but also some other equipment if the country really wants to track those. So in kind. So these are like provided from the central level. So whether they receive those in time when they were in need. So what they requested, whether they received the requested amount. So we see that not everybody received what they actually express as their need, and there are variation across different areas and also across different line items. But the public expenditure tracking helps us to track that who received what and whether at the right time. And those who have not received, definitely there are scope to improve that in the next planning process, that if some areas is not getting what they expected, so what are the reasons? Is it the reason that the local level could not plan properly, or is it something that the central level delayed, or some other bottlenecks? So these can be also tracked through interviews and also even more deep dive of these issues. So public expenditure tracking, the idea is that we get a picture of how these funds are flowing from different channels. I will not go through in detail, but this is just a glimpse of that, how we really want to see these the funds and data, or everything is flowing from one to another. So from the central level within ministry, there are different units. It is not very straightforward that Ministry of Health sends the fund to a district hospital, but there are different channels through which the fund flows, and this is really complex. So tracking those and tracking properly, accurately, as Joe was saying, that how accurate the data are. So this is not easy. So this needs a robust system in place to record those data, which the researchers can track. So unless the data is available, definitely it makes life even harder for us to track the services. So this is just to share an idea that how these systems operate from the Ministry of Finance. Fund goes to Ministry of Health within different units. From there, it goes to tertiary hospital, maternal child welfare centers, and even with the district level, there are civil surgeon office, and there are hospitals, and then Upazila Health Complex, sub-district hospital, and other types of health centers as well. And the data comes from multiple sources: IBUS, financial management, accounting unit, DHIS2, district hospital information system, the public expenditure tracking, some others. So multiple sources, you have to collect those and then cross-check that how you interpret all this information and then report back. So this is again not only the funding, the medical and surgical requisites, which is basically the medicine and other surgical requisites, include different types of supplies and other smaller logistics as well. So this is again very complex, because it is not only that from the Ministry of Health we are getting these, and the medicine within Ministry of Health there are different units, and development partners also bilaterally procure and they send to the district and sub-district level. So there are different channels through which these drugs are procured and then distributed, and some comes to the district level and then shifted to the sub-district level, and sub-district level can often procure them by themselves, and some they receive from the central level. So tracking all these is not straightforward. So it is always nice to have some flow diagram like this, whichever project or country we do it. So it's a nicer way of presenting. So I just showed just as an example that whether we can adapt that for chorus. A few issues very briefly, because we want to go to the breakout room and discuss a bit and reflect back. So this public expenditure tracking showed us that there is no mechanism to comprehensively capture the real-time budget. So we always have to wait for reconciliation, tally with different ministries, different units. So getting the budget, the fund release expenditure data, and monitoring the funding flow to the cost centers, that is the hospitals by district and sub-districts, it is very complex, and there is no mechanism in place. You have to dig down, you have to collect the data and then compile. No readily available comprehensive mechanism to capture this real-time data. So 1/4 of the health budget being unspent that I mentioned, this is really something we need to consider, and facility-wise allocation rather than needs-based. So we also, this is a long time discussion. I would like to acknowledge that Professor Tim Ensar, long back, I think in 2001, did a study in Bangladesh resource allocation process and the possibility of doing a needs-based resource allocation. We still cite that. We are discussing this for long. But I think though we have done some theoretical work, some small pilot, but in reality, still the budget are done for each facility like district hospital, Upazila Health Complex, not looking into the disease profile or number of population in the area. Sometimes the utilization rate, bed occupancy rate, but that is very clinical and not the population need considered. A number of challenges are faced in medical and surgical requisite procurement, and that's why I already mentioned the budget for medicine often remain unspent. And the PETs also confirm that a range of human resources issues, that there are vacancy, there are absenteeism, there are low competencies, low motivation, among other reasons for service quality sometimes became low in the country. So these all came up from PETs. So if we really want to use these information or these types of analysis for urban areas, because what we did was Ministry of Health and their allocation for the rural area. So we really need to understand the urban context, and we really have to define the scope of work, because in the rural areas, there is a structured system still that is very complex, whereas in the urban area, there are multiple actors, and multiple actors, I mean also even for the public sector, there is Ministry of Health and local government, there are different channels of providing resources. So we have to define that if we really want to do any expenditure tracking, what is the scope of work and whose expenditure we really want to track, rather than making it very complex and taking multiple actors. And also, as I was saying, the service delivery system also varies across providers. So maybe Ministry of Health or Ministry of Local Government, even city corporation and NGOs contracted by city corporation and city corporation own service. And even urban areas, there are other departments like Defense have their hospital, and Ministry of Social Welfare also spending quite a lot on urban health, and police department also have their own hospital. So do we want to track all of these? So defining them and focusing on maybe to start with a smaller bit might be helpful. And at the city corporation level, sometimes health budget is not also very well defined. So health can be, they sometimes define the vector control, like controlling dengue and others, and cleaning the houses, that also comes into health budget. And sometimes some beyond that, providing care. Healthcare. So how we are defining the health budget when there is no such health budget per se in many countries like Bangladesh? We only had a health budget code very recently. So it also poses a challenge. And availability of information. We have seen in many instances that the city corporation, as they have multiple tasks, having health or health indicators, health budget for a separate, information management system, sometimes lacking, and maybe sometimes not that robust. So collecting information from Ministry of Health and Family Welfare or Ministry of Population might be slightly easier in some contexts than compared to collecting information from local government. That also has to be considered when we consider to implement public expenditure tracking in urban areas. And of course, there is capacity and interest issue, whether they are really on board and do they have the capacity to provide the required information and provide the support for these. So what Chorus can address very briefly, maybe with a very limited work that has been done so far in Bangladesh. From that experience, what I can say that how much resources are used for health at the city corporation level itself can be a very nice research question, that how much city corporation is really spending. Even a small boundary, even in one city or two city, can be a very good starting point for Chorus. And who are financing those? Is it only city corporation? Are they getting something from Ministry of Health? Development partners, who are the development partners? So, and how much they are getting from the different partners, maybe that can be looked into. And also tracking the fund flows from the city corporation once they get the funding from different sources, actually how they are providing those to the provider level, and through what channel, how they are sending those resources, and what are the medicine and other logistic flows? Is it all procured by the city corporation, or Ministry of Health is providing some services? The NGOs are procuring by themselves. Development partners are procuring. Who is doing what? So I think tracking down that will be quite interesting. And human resources, we always say that in Ministry of Health in rural areas, retention of staff, absenteeism is a huge problem. So is this also true for the city corporation? Do they face the same problem, and what solutions they are suggesting for that? And ghost workers, this is an interesting term. Pets often used. I just thought to share that ghost worker is that on paper, there should not be anyone in that post, but you see someone, you arrive in the center and see that someone is working there who should not be there. He is not a staff there, but still he is working. So who is that ghost worker? So is there someone moving around? So all these, not only absenteeism, but some people who should not be there is also working there. Is it happening in the city corporation level? So I will stop there. Now handing over to again team that if there is any specific question, happy to answer, or we can go to the breakout room and discuss these questions. Team, over to you.